Welcome back to coding. So this semester we're going to start advanced coding. So we're just going to start off with our first PowerPoint, which is going to be just a quick review of what we had last year. So with that, let's start off with diagnosis coding for outpatient professional services. Remember, guidelines for diagnostic coding must be followed when assigning these codes. And then only diagnoses that currently relate to the patient should be coded. So again, these payment to these services may be tied to diagnostic coding, and then we're going to get a little bit into medical necessity. So again, how do we assign a diagnosis code? It has to be accurate because again, your inpatient services really are based on diagnostic coding. In the outpatient setting, the diagnosis code must correspond to the CPT code, so to the treatment or services rendered to that patient. So again, inpatient, we really concentrate on diagnosis. We're outpatient, yes we do, but we're looking at that CPT code and we're looking to make sure that our diagnosis code matches it. Sequencing. Okay, so we're going to talk a lot about principal diagnosis coming up here. You're going to have to be picking out a lot of principal diagnosis in some of the assignments coming up. So anyway, let's start off with primary. Primary is the first listed. It's related to the chief complaint on why they're coming in. And it's probably the main reason for the encounter. Where your secondary diagnosis, they contribute to the primary diagnosis. Not the underlying cause. So where your principal diagnosis, keep in mind, review that definition. These are only applicable to inpatient cases and claims. They're similar to primary diagnosis for outpatient. So again, remember the rule on principal diagnosis. After study what brought that patient to the hospital as an inpatient. Medical necessity, this is huge. Insurance companies may not cover procedures that are not diagnosis related. So with these situations, you're going to cover this probably in reimbursement more, but what we're dealing with is LCDs and NCDs. So for medical necessity, if we have a colonoscopy, we have to make sure that one of our diagnoses matches that medical necessity. Okay, so then we have ICD-10, which again, we use that for office and outpatient services. And we also use it for ICD-10 PCS, we use for procedures, again, just for inpatient services. Quick history, you've heard me talk about ICD-9, but boy, even back before that, there was a version in 1948 of ICD, International Classification, and then the 8th division came in, and then in 1979 we had ICD-9. They did a revision of ICD-10. This wasn't implemented until October 1st of 14, so this will be just hitting, 5 years. Transition from 9 to 10. Okay, so again, with this, there was a lot of transition going on. And students at that time, we had to educate them in both areas, 9 and 10. So a number of things also happened is ICD-10 exceeds previous systems. And the reason is because it expands to include health-related conditions. It provides greater specificity, which now instead of 5 digits, we have 6 and 7 digit characters. We also have crosswalks. We have mappings, which would take us to 9 to 10. There is software available that helps, but again, you shouldn't find too much of ICD-10 around anymore. Okay, so let's go to ICD-10 diagnosis and procedure codes. So again, it's again, much greater specificity, expansion of clinical information, it's flexible, updated medical terminology and classification of diseases, and you can compare mortality and morbidity rates easier just because our codes are more specific. Fewer non-specific codes in ICD-9. Same thing here. We have, everybody remembers our table of drugs and chemicals. Again, with that, we have to know if we have poisoning, adverse effects, underdosing. We have neoplasm table. So again, we need to know if we have the neoplasm table, we need to know if it's primary site, secondary site, malignant, benign, index to external causes. Again, everybody remembers those. You know, somebody fell out of a plane, somebody tripped and fell. All of those are external cause codes. We need to know where it happened at home, at work. The main code descriptor items are in alphabetical order. So as you can see here, we just go back to your main term, subterm, and then subterm. So again, you go as far as you possibly can go to get that code. Okay, just special points to remember in your alpha. The appropriate sites or modifier listed in alpha order under main terms. Then you want to go through all the non-essential modifiers. You want to look at eponyms. You want to look for all sublisted terms. Locate a closely related terms, code categories, cross-reference. We also have the tabular list of diseases and injuries. These are composed of alphanumeric codes that represent diagnoses. And then remember, in ICD-10, these codes can contain up to 7 characters. So digit number 1 is going to be alpha all the time. 2 and 3 is going to be numeric, and then 4 to 7 could be alpha or numeric. Let's not forget our placeholders. Again, what this happened is if a disease or something comes up with something as a side effect, or they find more specific or specificity to that disease, that way they can add something and they have a placeholder for that code. You'll see these a lot in injury codes. Okay, so here we have special points to remember in the tabular list. Always use 2 codes when necessary. Okay, if 1 code doesn't describe it, you need to use 2. Search for 1 code when 2 diagnoses or diagnoses with an associated secondary process or complication is present. Okay, so again, some of these codes can be listed with 1 code. Use categories only if there are no subcategory codes. Then always read your instructional notes provided. Okay, these are different conventions, and we'll go through them. We already talked about abbreviations, placeholders, 7 characters. General coding guidelines are going to locate that term in the alphabetic index. You're going to verify it. Remember, you always have to use the tabular. And then if there's a dash at the end in the alpha, that means we have more characters. So keep that in mind. Again, your ICD-10 codes can be 3 characters, and they can go all the way up to 7. Go as far as you can go, because if you don't, it's going to come back and somebody's going to have to again go ahead and redo that claim. Signs and symptoms. Everybody remembers signs and symptoms. If I have a sign or symptom, so let's say I have a sore throat and they end up diagnosing me with strep throat, all I am going to do is code for the strep throat. So again, make sure you go through the guidelines for inpatient versus outpatient. Remember those rules on probable, suspected, rule out. So general coding guidelines, conditions that are integral part of the disease process. Signs and symptoms should not be assigned as additional codes. So if we have chest pain and the patient ends up being diagnosed with a myocardial infarction, chest pain should not be coded. Multiple coding for a single condition. This would tell you, that's why it's always important to read your tabular. Use additional code. Code first. It tells you what to do. That's why you always need to look in the tabular. Acute and subacute. Remember, if we have acute and chronic and they're at the same indentation level, I code them both. Okay, if it's acute and then chronic's in parentheses, then you're just going to code the acute because chronic is a non-essential modifier. Sequela also means late effect, impending or threatened condition, reporting the same diagnosis more than once. Again, you can never ever report a diagnosis twice for one encounter. Laterality, the final character should tell me if it's left or right. Documentation for BMI, so body mass index. We also have pressure ulcer stages. Again, make sure you look for this documentation. We have syndromes as a symptom complex. We have documentation of complications of care. Chapter specific coding, I'm not going to go through this right now, but just review it in the PowerPoint. Okay, so we're kind of finishing up here. Handy hints, identify important references, add table to the main section of your alpha index. Again, we have a tabular list, drug and chemical table, or chemical table. And then a lot of times they tell you once you get out in the workforce, keep a list of your diagnostic and CP procedures that you use a lot. Consult payer guidelines. Okay, computer-assisted coding. This generates medical codes after they review the documentation. But one thing you remember is a coder needs to go through that. So if you have any questions, let me know, but hopefully this was a good review. We'll be having some more PowerPoints coming up.